Hello, and welcome to the episode where we discuss some scientific topics regarding the pulp reaction to the caries and the dental procedures. How does the pulp react to the caries invasion? In three ways: by decreasing the dentin permeability, by doing what is called the dentin sclerosis, or by forming the tertiary dentin, or by inflammatory and immune reaction in the pulp. Uh, these three may happen by altogether, or or some of them may happen and other not, depending on the situation and the rate and the speed of the caries invasion. We will talk in details explaining the three ways. First of all, let's talk about how the tertiary dentin form. When the pulp is exposed and there is a bacterial infection, which means that these bacteria are releasing their toxins, they induce an inflammation. And their acidic byproducts that reaches the dentin, they do what is called the degrading of the dentin matrix, which means that they affect the dentin matrix, releasing what the dentin has of a bioactive molecules that were previously been protected inside the dentin tubules when the dentin was forming. So these acidic byproducts, they liberate these molecules, the bioactive molecules, to resume their role in the dentin formation. So these acidic byproducts reactivate these molecules to form the dentin again, but this time the dentin that is forming is a tertiary dentin, that the tubules have different orientation from the secondary dentin, the original one. Also, the acidic byproducts and the toxins that are produced by the bacteria, they induce some growth factor that aid in this procedure. But the formation of the tertiary dentin takes time, so it's not regarded as the first line of defense, but the dentin sclerosis is the first line of defense. So what is the dentin sclerosis? It is an increased deposition of the intratubular dentin and the direct deposition of mineral crystals into the narrow dentin tubules. So the purpose of this is to decrease the dentin permeability, and to here, for example, we can see the sclerosis under this restoration to decrease the reach of any toxins that may cause an irritation to the pulp. We can see here the crystal deposition in the dentinal tubules under the microscope. This is the at the tertiary dentin formation. We can see that the change in the direction of the tubule. Now let's discuss the third way of pulp protection, which is the immune pulp response. That is humoral and cellular, and the pulp react by doing this immune reaction. It does not need to that the caries is big and there is a huge loss of the dentin, or there is a direct contact between the bacteria and the pulp. This inflammation immune response can be initiated by the toxins of the bacteria that reaches the pulp from a small pit caries. This explains why small caries cavity can cause symptoms to the patient. There are some receptors on the pathogen that are called the PMPs that are recognized by the odontoblast. When they are recognized, the odontoblast initiate the formation of the cytokines and the chemokines that they stimulate the immune effector cells as well as direct bacterial killing mechanisms. So we can see here the dendritic cells, immune cells, also the lymphocytes come to the area. This is for the cellular response, immune response. For the humoral response, which is expressed by the IgG or the IgM and the IgA for doing an antibiotics that are transported to the lesion site and help in the protection of the pulp against the bacterial invasion. So the odontoblast play a central role in orchestrating local and chemotactic inflammatory responses to the dental caries, whether, as we said, it was cellular with the immune cells, or humoral that is expressed with antibiotic formation. Polyp is a form of pulp exposure in primary and immature permanent teeth that causes a proliferative response of the pulp against these pathogens to prevent the deep pulp from getting necrotic and lose its vitality. The treatment is in a conventional root canal therapy or therapeutic pulpotomy. The bacterial invasion does not only initiate immune response but also a neuro response, which is the releasing of the neuropeptides that increase the vasodilation and increase the vascular permeability, which increases the pressure in the pulp due to the blood flow that can progress to necrosis in extreme and persistent circumstances. The author is saying that there is no clear correlation between the symptoms and the degree of infection of the pulp. For example, the patient may be suffering from an reversible pulpitis symptoms, but histologically the bacterial invasion did not reach further than the coronal part in the chamber. And this is important that when we do the root canal therapy, we must distinguish between the different types of the pulp, and if we find that only the coronal part is infected, so we can do the pulp, the vital pulp therapy. And the lack of response to the electric pulp testing, we know that it indicates that the pulp has become necrotic. So the pulp testing only gives us 80% of accuracy regarding the degree of inflammation. Some caries, when we can find that there is now let's discuss the dentin hypersensitivity and its effect on the pulp. We can see that the hypersensitivity is seen under the microscope as the enlargement of the dentinal tubules lumen. This is a normal dentin that the lumens are closed, and this exposure produces a movement in the fluids inside the tubules that produces the pain. Also, this exposure is because that this dentin is not fully covered by enamel or by cementum. So some agents can be applied like the potassium nitrate, strontium chloride to close these dentinal tubules, lumens. Also using a toothpaste that is desensitizing has shown to give very good results in decreasing the symptoms of the hypersensitivity of the dentin over a period of 6 months. What about the pulp reaction to the restorative procedures? There was a study that have been made on 122 teeth. Some of them had crowns and the others are bridges. In a range of observation that ranged from 14 to 15 years, the crowns became necrotic in 15% of the cases, and the bridges had necrotic cases of 32%. The abutments became necrotic, and there was increase in the loss of the vitality of the anterior teeth more than the posterior, with a range of 54% of anterior abutment that became necrotic. And they are saying that what affects this percentage is the state of the abutment when we were doing the preparation, if it had a previous caries, or we used an excessive heat while doing the preparation. So they are emphasizing on the importance of using water and air spray to cool the surface. Recurrent caries under the abutments and the bridges are also a great cause of losing the vitality of the pulp. Etching also, which is a high acidic agent, causes some inflammatory to the pulp, but in a range that is acceptable and reversible. We have seen that there was an increase in the secondary dentin deposition under restorations. The normal range of daily deposition is 0.8 micromillimeter per day, but it increased to 2.9 micromillimeter per day following the restorative procedures, which means that there are some toxic materials that are released from these restorations that are causing these response from the pulp and increasing the deposition of the dentin as a barrier of protecting the pulp. By understanding this mechanism, we developed what is called the bridge, the dentin bridge, that we simulated on purpose in the direct pulp capping, where we use calcium hydroxide or MTA that causes a layer of a necrotic pulp that induces the sclerosis of the dentin by promoting a crystal precipitation with the tubules, combined by the reduction in its permeability. So the first layer under the calcium or the MTA or the calcium hydroxide is a necrotic pulp, and this necrotic pulp induces the sclerosis of the dentin and decreases the permeability that causes what we see under the microscope and call it as a dentin bridge. So it is an inflammatory low-grade change. Also, there are some proteins that are liberated from the dentin that help in formation the hard tissue, which is the dentin bridge. And glass ionomer is not recommended to be used as a direct pulp capping material, because the release of the high concentration of the fluoride damages the pulp tissues, and it is considered as toxic to the pulp. What about the pulp reaction to the vital bleaching techniques? The histological analysis of the pulp following the bleaching for up to 2 weeks showed minor inflammatory changes in the pulp of the bleached teeth that were reversible. So all the techniques of the bleaching and with different materials and concentrations are considered safe, and the effect of the inflammation is reversible in most of the cases. Finally, what about the mechanical irritants to the pulp when we do the orthodontic movement? They are saying that there is blood flow alterations that are not confined only to the tooth in the active movement, but there is an increase in the adjacent tooth to the focused tooth, and this alteration of the blood flow is temporary, and it returns to its normal range after we finish applying this mechanical forces. However, when the forces are extreme and not well studied, these circulatory interpretations can result in pulp necrosis. Also, when doing the orthodontic surgery, we are taking 5 to 10 millimeters of a safe space between the site of the surgery and the teeth, caused minimal disruption to the tooth vitality, and the blood flow is regained within months of the surgery. That's it. Salam. 3 basic reactions tend to protect the pulp against the caries. First, the decrease in dentin permeability due to dentin sclerosis to the combination of an increased deposition of intratubular dentin and the direct deposition of mineral crystals into the narrow dentin tubules to decrease the dentin permeability. The tertiary dentin formation, when the pulp is exposed, bacterial metabolites, toxins, and cell wall components induce inflammation. Therefore, acidic byproducts of the caries process act indirectly by degrading the dentin matrix, thereby liberating bioactive molecules previously preserved during dentinogenesis. Once liberated, these molecules resume their role in dentin formation, this time being stimulatory for tertiary dentin formation. Inflammatory and immune reactions in the pulp. Odontoblasts can recognize these receptors' pathogen-associated molecules patterns, which are called the PAMPs, on the surface of the invading organisms and initiate a host defense. Once these odontoblasts are stimulated by the pathogen, a pro-inflammatory cytokines, chemokines, and antimicrobial peptides are elaborated by the odontoblast, resulting in the stimulation of immune effector cells as well as direct bacterial killing. What about the pulp reaction to restoration? It was shown that in the normal rate, a secondary dentin deposition was about 0.8 micromillimeter per day, but it increased on average of 2.9 micrometer per day following the restorative procedures. Pulp reaction to harm setting calcium hydroxide or MTA pulp capping. Application of calcium hydroxide to intact dentin appears to induce sclerosis by promoting crystal precipitation within the tubules accompanied by reductions in permeability. The pulp reaction to vital bleaching techniques, histological and analysis of the pulp following the bleaching for up to 2 weeks showed that there was minor inflammatory changes in the pulp of the bleached teeth and they were reversible, so the bleaching techniques are safe. The pulp reactions to orthodontic movement. If orthodontic forces are extreme, circulatory interpretation can occur, resulting in pulp necrosis, but in normal force application the blood returns to its normal flow after removing the orthodontic appliances.